Okay, if there are no questions, thank you, Shreyas. I'll go on to the cataract extraction using the femtolaser-assisted cataract surgery in difficult situations, as to how the femtolaser-assisted cataract surgery helps in difficult situations. So the femto, I would say, for the normal cases is obviously great, but it's a tool that helps in the challenging cases to simplify the outcomes about that. As you all know, that the femto cataract makes cataract more into a refractive procedure, because it does the following four parts. That is, it does a capsulorhexis, does lens fragmentation, does incisions, and also does LRI. Normally, I would take care of an astigmatism of up to 1 diopter with an LRI, and above that, I would go in for a toric intraocular lens. You can see that it gives you a good capsulorhexis. This is just to show you a normal femto procedure. As you can see, in a normal femto procedure, there is the image that comes. This is the OCT image that comes: anterior cornea, posterior cornea, the lens, and then you can see that this is the pupil, and then this is the capsulorhexis, and then you can make it into 4 quadrants, 6 quadrants, 8 quadrant, and you can also do softening of the nucleus. The entire procedure, the total time taken is always almost less than 1 minute, and you are able to get these things done, and then you can take away the points. I'll just wait for Dr. Tityal, otherwise we can have the polar cataract done a little later. That has to be done. Now, the second thing is that supposing you have to do a femto laser in a pupil that is small. So if a pupil is small, what can you do? They say that small pupil or dense corneal opacities are contraindications. I would still say that a dense corneal opacity is a contraindication. But when you are doing a femto procedure in a small pupil, you can obviously put a Malyugin ring or a Bhattacharya ring. You can't do the 4 iris hooks, but you can do this. Leave the viscoelastic inside if you want, and then increase the energy threshold that is going into the eye. Or you can do a wash of the viscoelastic, and with the fluid you can go ahead and do this. So this is just to show you the another case. Apart from that, this is with an ICL. Just to show you, in an ICL, you can see this is the ICL. The anterior capsule often is mistaken by the ICL. The second thing that happens, so you have to match this. The second thing that happens is that the pupil, you can see I have enlarged the pupil. I'll just go back. If you see here, this is the pupil which is smaller, which you need to enlarge. See this, and because it is the optic of the ICL which is picked up as the pupil. So that is something which is very important. You can get, if you have followed these two things, that is the anterior capsule has been done well, as also the pupil has been identified. You can see that you get a great capsulorhexis. You get a great situation where you have already done the nucleotomy. You just have to push out the ICL into the anterior chamber, and then just pull it out, hand over hand technique, and then you can see that you can go ahead and do the phacoemulsification procedure. So a complex situation of an ICL really becomes simplified if you are doing a femto procedure. This is the small pupil that I was talking about. I showed the picture of the small pupil. So you can see here, this is the entry that is going in, and then you are putting a Malyugin ring. We have the pleasure of having Dr. Boris Malyugin with us in this conference, but you can see this is the Malyugin ring that has been put, and then you go on to the laser machine. So this is the a case of a subluxated cataract. You can see that we are doing a good capsulorhexis. We are getting a good incision nucleotomy that is there, and this is that you can easily go ahead and this again you can get good results. Now let us look at a condition called as phacomorphic glaucoma. If you have a phacomorphic glaucoma, and if you enter the anterior chamber and do a capsulotomy with high pressures, you are going to get an extension of the capsulorhexis. This is a fantastic indication for a femto, because you can see here, this is such a swollen lens. Can you see? You can see that the iris is touching almost the back of the cornea. This is an LRI incision that is being planned. See here, this is it, and just see the kind of fluid that came out. The biggest advantage of a femto procedure in an intumescent cataract is that you are able to work on a closed chamber. So if you are working on a closed chamber, there is going to be almost negligible chance of a runaway. And you could see that the capsulotomy was good. The only thing is, because of the fluid coming out, you just need to always stain it with trypan blue, and once you stain it with trypan blue, if there are any skip areas in the capsulotomy, that can be taken care of. Now this, you can see, this is a case that came to us with an angle closure glaucoma, a young lady who was recalcitrant to any treatment, and just look at it, we did an anterion, and you can see in this particular case the huge lens that the patient had, and the lens thickness was 5.85 millimeters. So what do you can see that Von Herrick, you can see that the iris is almost at the back. So what we did in this particular case was that we did go ahead and did a femto procedure, again with a very shallow AC. We were able to do this thing, and we did a surgical iridectomy. The patient was fantastic, and this, you can see, is the post-op picture. I showed you the pre-op picture. You can see this is the pre-op picture on the anterior, and see the post-op picture. This is the PI that is there, and see the depth, and you can see from a 5.85 millimeter, this is the artificial lens or the pseudophakic, which is allowing you for the whole thing to fall back. So in angle closure glaucomas also, you can have phacomorphic, I told you, but without a cataract. If you have very large lenses, you can go ahead and do it. Then let's come to rock hard cataracts. If you look at rock hard cataracts in this particular case, you can see that this is a good nuclear capsulotomy. You make a larger capsulotomy with femto laser, which is about 5 point. You saw those air bubbles coming, and you can see how the good cleavage in a black cataract that you have, that is there, and it helps you remove all of this very well in the cases of even black cataracts. This is the post-traumatic subluxation. The important thing, what Dr. Hemlata, I don't know whether did you show this video? She's already shown. So we have already talked about limited pars plana vitrectomy for optimizing surgical outcomes that are there, and we get good results. This is the post-traumatic subluxation. Can I have Raghav on the dais? You have there, or you want to present for him here? Okay, so this is Dr. Tityal is not here, so I've just told Raghav to take care of the management of a posterior polar cataract using the technique of femtolaser assisted cataract surgery, because that is the go-to procedure. If you have a posterior polar cataract which you feel is not going to work, then you should look at the femtolaser assisted cataract. So what I feel is, in my personal practice, 80%, about 75 to 80% of my cases I'm doing with femtolaser. And as the technology of femto cataract has evolved, it has found widespread use in complex cases. And I feel it's a time to take the leap of faith and switch to the power of femto for these complex cases. Thank you very much for your kind attention. Thank you.